Jane is wandering around the dental offices. She seems so anxious. Is there something wrong with her? Oh, one of her teeth is missing. She's thinking about all the horrible things that might happen. It looks horrible to me too. Oh my, he must be a doctor. Why don't we see what he has to say? The dental office doesn't seem so scary. Jane is talking to the doctor. Oh my, she can't stop thinking about that scary knife. If he is not lying, maybe surgery without using a knife is possible. He even showed a picture, so it must not be a lie. I hope.
Hello everyone. So today I am with you on such a wonderful platform of webinar series being happening. I know these are the compulsory holidays declared by the dreaded corona, and we are all at our homes quarantined. In these times, we have an ample opportunity to learn, increase our knowledge, revise some basic fundamentals, and share our experiences. So let's avail this opportunity. I am here be with you to discuss something about implant prosthetics and some clinical tips, my experiences, and some advices which I have been doing in last clinic practice. I am Dr. Somesh Grover, practicing in Gurgaon for last 17 years. Now, we have been doing implantology for many years. I know there are some beginners who may be watching this presentation. And in this implant rehabilitation, we always have something in mind that we have to bury some implants and we will get something from the laboratory and we will rehabilitate the patient. But mind it, all the clinicians should have a final treatment outcome, that is the prosthetics, in mind before you start a treatment or at the time of diagnosis. And often this is the important thing which is missed out by some clinicians, and these are the basic principles to be checked at the time of diagnosis and treatment planning. In this presentation, I have discussed many cases of mine till the prosthesis is delivered. Now the main thing I want to tell that this is the instrument, I call it a SurgiGuide as an instrument which gives us the best precision, and it is derived out of the patient's anatomical data of CBCT which is given, and finally the prosthesis is designed completely digital milling and digital fabrication of the design is done by the laboratory. It's been done for many years now. And finally, the outcome comes to the clinic and goes to the patient's mouth, which is having a highly precise margins and very nice proximal contacts. It doesn't require any alterations and it just goes and fits nicely. So what I mean to say is we have been doing so much of freehand dentistry which in which we enter so many complexities, and this digital implantology offers us so much of simplicity. So let's see this case where we want to rehabilitate the implants and the teeth in this region of 3.6 and 3.7. The patient has a simple complaint of inability to chew from the left side. Since right side he is having a nice big natural molar with crown. So in this case, I know that we cannot go for impressions as there is a big underlock behind the old fixed PFM bridges which he has. So I decided to go for digital planning. So once we send the results, see the results with the CBCT, the digital planning is decided by the clinician. All the data is sent by email. And in this, we can see that 3-6 inserting the implant is at a very nice position in the bone. But in 3-7, as we all know, there is a submandibular fossa. So if we put this type of design, the prosthetics, we are seeing that it is not at a good position and it is flouting the principles. So we will decide implant position like this so that we are having a prosthesis coming out like this in the neutral zone. So this help is there with the digital planning. And finally, we finish this case and a very nice prosthetics is made. These are the customized abutments and we finish the case in a few months. And I have taken this OPG after many years, couple of years. What I mean to say is, if we go freehand implantology without deciding for the prosthetics first, this is totally a blind game. We should not practice. Instead, we should go digitally when our implants are placed parallel to each other, even in the full mouth. The final prosthetics will be super. And this is all the help given by the fully digital process till we get the prosthetics. It's one-stop shop. Now let's see another case where the patient came with limited mouth opening of almost 20 mm in front, but posteriorly there was difficulty I could judge at the time of diagnosis. So I decided to go for digital planning and I got a beautifully made surgery guide from DO Implant Company, which is one of the thinnest, and it was very easy for me to insert the implants right at the nice position at the time of surgery and at the time of feeling nice gingival cuff. And finally inserted the H-scan bodies and send him again for the IOS. At this stage, I can say you have to treat the patient very delicately. Do not air blow this gingival cuff and do not destroy the anatomy. Soft tissue is still on a healing phase. Another thing I would advise that when you have to decide for the shade, and in these cases, when the HTML files have been sent to the lab and they will make the customized abutments as well as the final FPD in one go. So they had sent me some staining when they had done and I had cropped it on such a easy softwares of Piccollage and Adobe. You can cut out, crop and put it on your own photographs and decide with the technician that which shade is matching and in which light the shade is being taken. And finally, you get that prosthesis on the 3D printed models. In this case, I had decided for a screw retained as there was a very limited mouth opening. But the excellent thing is both the implants was so truly parallel that the prosthesis fits very nicely. Finally, screw torqued at around 40 NCM. These pictures are taken couple of days after the prosthesis. You can see the buccal cast out of occlusion. So this is the initial when the patient came and these are the implants inserted with the H-scan bodies and the final implant prosthesis in place. Another case of single edentulous area. In this, generally we would see that whenever we go for anterior teeth, either we want, the best thing is that screw should come out from the palatal cingulum side, but in some cases we would see that it come from labial or directly from the incisal edge. But in the first case, we would see that this we will not accept, this almost the class 1 horizontal deficiency of bone, and in this case this is the acceptable, but this is the best. So in these type of situations, both the latter type of situations, we can go for the anterior teeth implant placement. In this case, we had the middle one. We can see that we have limited amount the bone. Even the 3 mm diameter implant, we had a nice torque on the day of implant. So this is an IIT student. The complete digital planning was done, implant inserted, abutment inserted at that stage. So in the prosthetic design, the main thing which we want is that bone, labial cortical bone expansion, which we can appreciate. And finally, these are the most difficult cases to rehabilitate single central incisor, and it comes out very nicely cemented. So these important things we can discuss, that the efforts of clinician and laboratory are decreased when we avoid some physical impression procedures and go digitally with iOS. And moreover, I can say that artificial engineering is going to give us a complete implant navigated robotic surgery, leading to a perfect prosthesis, and further the dentist's efforts are going to be reduced. Now, how about this case? I know that in this case, I had to put 2 incisors. But if I straight away open the gingiva here, make an incision, and go for freehand implantology, I may incur problems. So in this way, I can say that imagination you have to have, that what will be there under the bone. Knowledge definitely helps. So when we plan for a digital planning, we see that if we put 2 prosthetic teeth and go for the thinnest diameter implants, they come in red. That means it is not possible to give a proper bone gap in both the implants. Even the implants are touching very close to the adjacent natural teeth, lateral incisors. So we decide for a single implant in this case, and we could have even gone for a single implant on either side and go cantilever, but my personal experience is that it will be more detrimental to have a leverage of one full central incisor on one side. Cantilever is not good for future. So I decide to place the implant in the center, away from the lingual plexus, and completed the case. This complete design was done in the lab, digitally planned, all the finished lines. You can see even the customized abutment is fabricated and shared by the clinician. The design, when it is approved, you can go for the final prosthesis. And I am so happy with all this digital technology being offered by DO company. Now, advantages we have that these are so passive when the intraoral scanning is done. So they are having a low morbidity and very easy to fit, almost none tissue manipulation. So this all decreases the chairside time, for which the patient is very happy. And I have never seen any complication in fitting the prosthetics. So it gives a higher predictability and highest of success rate. How this prosthetic driven planning helps us in our day to day practice, I shall tell you. As you receive a edentulous case or a partially edentulous case, if we plan prosthodontically, decide its prosthesis first, that is crown down approach, and then plan for the placement of position of implants, it helps in better occlusal force distribution, better judicious choosing of the abutments, and the post surgical management or longevity of the case is very high. And when executed, you would always see that these implants are highly parallel, excellent prosthesis comes out. So these merits of 3D placement are just excellent. In this, first the crown is planned with the most important antagonist tooth, functional cusps, and then the placement of implant is done on the software, and this is shared with the clinician via emails. And I am so thankful to DO company for giving us the opportunity and provisions for doing our cases in an excellent way. This was one of my initial cases I started 2.5 years back, and with simple case of edentulous tooth, a customized abutment being placed, and temporary crown on the same day. Wonderful results. Another case I would like to discuss, this is an immediate implant placement where the root was extracted. This is a very interesting case to learn. While doing the implant, everything went all right, but when the abutment was placed, I was not happy with the position mesiodistally. It was slightly unequal. So I went through all those x-rays where the root was present and extracted. Osteotomy was done with the drills and implant was placed. And after that, the customized abutment was tightened, which was given along with the box of implant to be placed during the after the surgery was finished. But the angulation went wrong because of some soft bone present here distal to the apex, and on the distal wall there is a very hard lamina dura bone on the wall of the socket. So finally, with the while tightening, the implant got sucked in into this area slightly distally, tilting almost 5 degree mesial side coronally. Anyways, we finished the case, and later on we used this H-scan body and made a new customized abutment. So you can appreciate the previous abutment and a new abutment to correct for the clinical error. I can tell you clinically, this was placed initially while surgery, and the prosthetic abutment to change its plan, H-scan body was placed, which is quite mesial. And the lot of help was given by the laboratory to create this customized abutment, and the angulation was starting right from the hex distally. It was planned in such a way that it was not affecting the bone or the position of implant or the soft tissues. In fact, soft tissue healed nicely. You can see the conversion from here, left side to the right side. Excellent healing after placing the new abutment, and you can see how the cases have been improved. And a very super fine customized zirconia crown was placed and the case was completed, and this will be very long lasting. Now in some cases where the edentulous spaces are there, so these zirconia markers are used, and CBCT is done with the help of this triangular effect, and which helps us in partially edentulous cases. So in one of my cases where it had edentulous areas, so this splint manufacturing process is done in the DO lab, where this splint is fabricated with zirconia markers and the occlusal rims are fabricated, sent back to the clinic, and here we do all the jaw relations again and send this model to back to the CBCT center, and the patient wears this splint in occlusion oriented with the jet bite, and CBCT is taken, and this record is sent with the zirconia markers to the DO Navi center so that they can merge the two data of CBCT and iOS. So this phenomena was also applied in this case for prosthetics, where the patient required some teeth in the anterior zone, and edentulous area was there. So these zirconia markers were placed on the splint, and the patient was wearing the splint while shooting of CBCT. The whole process was done, GBR and PRF. Excellent results came. Temporization was done on the same day. And after a few months, this zirconia bridge was delivered. Excellent fit and perfect occlusion. Posterior planning is going on for this case. It will be done in a few months. I shall get back later. Another case where immediate tooth extraction was supposed to be done, and I was very keen to keep this buccopalatal width and the buccal fullness for future. So I sent him for planning. In this crown down approach, the implant position was planned. There was some apical disease also present. I could manage it easily. Immediate extraction was done, and the implant was placed at a palatal position. And after a few months, a judicious selection of H-scan body has supposed to be done and inserted an implant with the H-scan body. IOP X-ray is taken. Now here I would like to appreciate and emphasize the X-rays, the need of IOPs to be done after every connection to be checked. Like in this case, you would see that always we have to see that these two thread gap has to be there. But in sometimes when you see 3 or 4 thread gap, then you would definitely see the connection error at the coronal end also, and this needs to be checked every time, and IOP needs to be confirmed every time. So we continue with this case, and nice gingival healing, customized abutment fabricated, and even then when it is screwed and torqued in, 2 threads gap is to be checked. Even the distal crown was supposed to be changed, so we did it. And in the implant, again some tips I can tell you, that once you have torqued the abutment at around 20 NCM, then you can block the space of the screw head with the plumber's tape commonly available, and further top it up with the block it with rubber based putty, and finally cement the crown. And in these cases, I have used all the digitally available software data. The laboratory would share the HTML files to finalize the planning, and then it is executed. Occlusion and all, it's seen very nicely, and they send the 3D printed models along with the prosthesis. Two separate crowns have been made, one on the implant and one on the natural tooth. Nice proximal contact. Opposing model, 3D printed model, is also there to check buccal disocclusion, cusps, lingual proper occlusion for better chewing. Nice processes, excellent. And this all help is given by the laboratory and Dio Navi company. Once we cement it, we again check the x-rays. Excellent occlusion, happy patient. Now in this digital world of implantology, I would like to say that we have to unlearn some old concepts of analog implantology procedures and learn some wonderful digital planning. Now in this case, there is a planning of sinus lift as well as single tooth implant and its prosthetics. Planned everything digitally, crown down approach, everything perfect, and executed. In case of mandibular, I felt a little reduced mouth opening, but could be easily managed with the surgery guide. And in this type of procedures, I would always say that surgery guide is such a beautiful instrument which helps in the completing the case prosthodontically in a wonderful way. So implant is talked, and I would like to emphasize that I'm just revising some fundamentals and basic facts. So the complete customized abutment is done and the complete PFM crown is placed. And upper sinus lift case, all the procedures executed clinically, surgically, implant placement. While doing the prosthetic customized abutments, this device, the jig, is provided, which allows us to place the customized abutment at the right positions in respect to the adjacent teeth. And once it is done, you can appreciate and admire its position clinically with nice photographs, and you can put the combined united splinted temporary crowns. Yeah, in this case, I always also want to discuss with you that while placing the customized abutment, I faced a little difficulty, and this is the because of inadequate use of profile drill. You can see the bone is still present here. With multiple X-rays I tried, but I couldn't achieve. So once the abutment profile drill, which is at the while doing the clinical work, it is usually omitted. Even the drill protocol is done thoroughly, but while doing first implant, second implant, and third implant, so you tend to forget one odd instrument, and it reminds you that surgical protocol has to be followed for making the wonderful prosthetic protocol. And then this customized abutment was fitted nicely, and the case completed with the finals, control side, left side, and final PFM abutments, PFM crowns placed, joined and splinted, So this case was completed. Earlier, I had done the freehand implants on the left side, and I could easily compare that I am not happy with my own work, which I had done in the past. But with a fully guided, I was very happy with the parallel placement. So there will be better distribution of forces while the patient is chewing from the left side. And this case was completed. Even for the fourth quadrant, the case is going on, and I will come back with the completed case. Now, there are some take home points. I would always appreciate that osseointegration is one of the basic components in implantology. But when we compare and decide and discuss the digital implantology, we would always emphasize more on the processes, fabrication, and its placement three-dimensionally in a perfect position. And as the technologies are evolving, the surgical techniques are almost the same, but the fundamentals of the prosthetic placement has to be remembered. Though we always revise our books, textbooks, final year BDS, you remember the textbook of Bouchers and Fenn are required to execute the prosthetic treatment protocols to avoid failures. And this prosthodontic driven treatment planning is very important to be executed scientifically rather than to depend on any other procedure. And these prosthetic protocols have to be executed with ethics and focus on the patient care, and it will give you definitely high predictable outcomes. I am always there on email. You can contact me for any questions or any advices, any discussions. Thank you so much. Signing off, Dr. Somesh Grover for now.